Have you ever really stopped to think about those common childhood illnesses? You know, the ones we often just sort of shrug off as just part of growing up.
Yeah, measles, mumps. Seems almost nostalgic now for some people, maybe.
Right. But what if I told you that beneath that simple surface, some of these diseases hide incredibly complex, like viral details. And surprisingly, they can have direct, pretty profound impacts on your overall health, including your dental well-being.
That's the fascinating part, isn't it? The connections.
Exactly. We're talking about insights that could genuinely change how you view something as, well, as routine as a dental checkup. Maybe even transform it into like a front line for spotting broader health issues. So today on the deep dive, we're not just scratching the surface. Oh no. We are peeling back every single intricate layer on two specific viral adversaries, measles and mumps. We've been handed this really comprehensive stack of sources for this deep dive. Seriously, everything from highly detailed medical descriptions, sharp clinical insights, to absolutely crucial information specifically geared toward dental professionals like you listening.
Yeah, it's quite the collection, a real gold mine, like you said. And our mission, really, for this deep dive is exactly that.
Yeah.
To dissect these two viral infections right from the ground up.
Yeah.
We'll look at their tiny cellular structures, how they're actually built.
The nuts and bolts.
Precisely.
Yeah.
All the way to tracing their journey through the body, their systemic effects, how they spread.
Yeah.
But more critically, and this is where it gets really interesting for our listeners.
Yeah.
We're here to uncover their direct relevance and their significant, often quite surprising impact within the dental world. I think there'll be some genuine aha moments, facts that might just make you rethink what you thought you knew about these seemingly simple childhood bugs.
Absolutely. I felt that way just reading the sources. So buckle up, join us as we unpack these viral mysteries piece by piece, almost like forensic detectives, right?
Yeah, maybe viral detective.
Viral detectives, I like it. By the end of this journey, you're going to feel truly well-informed, not just about measles and mumps themselves, but about how interconnected our body systems really are, and indeed how our various healthcare fields link up. It's a powerful lesson in that holistic understanding. Okay, let's begin then. Let's set a sort of foundational understanding for both of these viral adversaries.
Place to start.
So when we talk about measles, which medically is known as rubeola and mumps, we're dealing with acute infectious diseases. They share a pretty significant common origin. They're both caused by members of the paramyxovirus family.
Right. That's key. Paramyxoviruses.
So what does that actually mean? Well, they're classified as enveloped RNA viruses. So try to picture this. Their genetic blueprint, which is RNA, is encased within a protective protein shell.
The nucleocapsid.
Right, the nucleocapsid. And then, crucially, that's surrounded by an outer lipid envelope, almost like a greasy cloak that helps them sort of evade detection and get into our cells.
Yeah, that envelope is super important for entry.
And here's a critical shared strategy right at the start of their attack. After getting into your body, both viruses begin to multiply really rapidly right there in the respiratory tract.
The airways, yeah.
From that initial foothold, they then spread throughout the body systemically, leading to this cascade of manifestations that can affect multiple organs, way beyond just, a cough or a swollen gland.
That's a fantastic starting point because you're right. While they share that broad family classification and that initial entry strategy in the respiratory system, their individual characteristics and the specific pathways they take through the body, they're actually quite distinct.
Okay.
So let's really dive into the measles virus first. Rubeola. Morphologically, meaning its shape and structure, it's typically described as, spherical, a little ball, though sometimes it can be a bit pleomorphic.
Pleomorphic.
It just means it can vary a little in shape, not perfectly round all the time, like a slightly squishy ball maybe.
Gotcha.
And it's tiny, really tiny, measuring roughly 120 to 250 nanometers. I mean, to put that in perspective, you can line up tens of thousands of them across the width of a single human hair.
Wow. That's hard to even imagine.
It is. Inside this microscopic sphere, it houses its negative sense RNA genome. Now, for those of us who aren't virologists.
Which is most of us.
Exactly. Think of a negative sense RNA genome like a photographic negative. The virus can't directly use this negative to build its parts. It first needs to make a positive copy of its genetic material, like developing the photo.
Okay, that makes sense.
So this genome is packaged within a helical nuclear capsid, basically a spiral-shaped protein structure protecting the RNA. And all of this is then surrounded by that lipoprotein envelope we mentioned earlier.
A greasy cloak.
That greasy cloak, yeah. Now, that envelope isn't just a simple protective layer. It's absolutely crucial because it's studded with these key surface proteins. They act like the virus's tools for interacting with our cells.
Tools? Like what?
Well, we have the hemagglutinin, or H spikes. These are vital for the virus to attach to your host cells, essentially like little grappling hooks.
Okay. H for hemagglutinin, the hook.
Exactly. And then there's the fusion, or F protein. This one is incredibly important because it mediates cell fusion. It allows the virus to literally merge its envelope with your cell membrane to get inside.
Sneaky.
Very sneaky. And it also allows an infected cell to fuse with a neighboring healthy cell. So the virus can spread directly cell to cell, often bypassing the space outside the cells where your antibodies would normally be waiting to neutralize it.
Ah, so it avoids the main defense system that way.
Sometimes.
Yes.
It's a clever tactic. This F protein also has hemolytic activities, meaning it can break down red blood cells, at least under certain lab conditions.
Okay. H and F proteins on the surface. What else?
Underneath this envelope, there's a matrix protein, or M protein. It plays more of a structural role, kind of holding everything together from the inside. And, interestingly, this virus has a specific ability. It can agglutinate monkey erythrocytes.
Agglutinate, meaning clump them together.
Yeah, it clumps their red blood cells together in a lab test. But, and this is a subtle difference from some related viruses, it doesn't have neuraminidase activity. So the clumping, the hemagglutination, isn't followed by elution, meaning the red blood cells don't then separate again. It's a small detail, but a distinct characteristic.
Wow. That's a fascinating look at its microscopic architecture. It really is like understanding the blueprint of this tiny invader. So with this sophisticated structure, what's its actual invasion strategy once it gets into the body? How does measles spread, and what's its journey look like from that first contact to full-blown symptoms?
Right, that's the critical next step. Tracing the fascinating, albeit concerning journey of measles through the body, its pathogenesis and clinical features. Firstly, it is incredibly contagious, almost frighteningly so.
You hear that a lot about measles.
You do, and it's true. We're talking about a disease that spreads remarkably easily from person to person, primarily through aerosols.
Yeah.
Those tiny invisible droplets that come out when someone coughs or sneezes. And they can linger in the air for hours.
Hours. Wow.
Yeah. It typically enters the body via the respiratory tract you breathe in those droplets, or maybe through the conjunctiva, the membrane lining your eyelids. This high level of aerosol transmission makes it really challenging to contain because just being in the same room as an infected person can be enough.
Okay, so it gets in through the air or eyes. Then what?
Well, once inside, the virus doesn't immediately announce itself. It starts by replicating locally, sort of setting up a base camp in the epithelial cells lining your trachea and bronchi, your main airways.
Right.
Within about 2 to 4 days of this initial replication, it makes a crucial move. It disseminates systemically. It spreads throughout your entire body. Mm-hmm. Often it hitches a ride on lymphocytes, a type of white blood cell, and possibly also pulmonary macrophages, which are immune cells in the lungs.
So immune cells actually help spread it.
It seems that way, yes.
Yeah.
They pick it up locally and then carry it elsewhere. This widespread dissemination leads to what we call viremia.
Viremia virus in the blood. We heard that term earlier.
Exactly. Virus circulating in your bloodstream. And from the bloodstream, it can reach a whole host of target organs and tissues all over your body. The conjunctiva, affecting your eyes, the rest of the respiratory tract, the urinary tract, the lymphatic system, a key part of your immune defense, the blood vessels themselves, and significantly, the central nervous system.
Wow, it really gets everywhere.
It does. And this wide distribution explains the diverse and, widespread symptoms we eventually see.
So after this initial spread, this silent phase, what happens next?
Following this initial silent spread, there's an incubation period. This typically lasts between 8 and 12 days. During this time, the infected person usually shows no symptoms at all. It's a real stealth phase.
8 to 12 days is quite a while to be infected without knowing.
It is. Then the prodromal phase kicks in. This is a really crucial period, often lasting 2 to 4 days. It's marked by a combination of general, sort of flu-like symptoms.
Yeah.
A high fever, malaise, just feeling generally unwell.
Oh. Yeah.
Yeah, totally bought. Anorexia or loss of appetite, conjunctivitis red, watery eyes, a persistent cough, and coryza, which is basically a runny nose. Photophobia or sensitivity to light is also pretty common.
Sounds miserable. But you said this phase is crucial.
Absolutely vital to understand this. The prodromal phase is the period of maximum infectivity.
Maximum, more than when the rash appears.
Yes. This means that even before the classic skin rash shows up, the infected individual is highly contagious, unknowingly shedding the virus. This silent transmissibility during these early stages makes containment and early diagnosis incredibly challenging for public health officials.
That's a huge point. Contagious before the visible signs. And didn't you mention something earlier, or maybe it was in the sources, about a truly unique, almost fleeting sign? Something that appears right in the mouth during this highly infectious phase. That sounds like something a dental professional might spot first.
You're absolutely right. And here's where it gets really interesting, especially for everyone in the dental field listening. Right smack in the middle of this prodromal phase, typically about 2 days into the illness, a pathognomonic sign appears. Koplik spots.
Koplik spots. Pathognomonic meaning it basically screams measles.
Precisely. If you see them, it's almost certainly measles. And they're not just any spots. They are described very precisely as bluish-white pinpoint lesions. Imagine tiny grains of salt, each surrounded by a distinct dark red areola, like a little halo.
Bluish-white dots with red halos. Okay. Where exactly?
Their location is also highly specific, which makes them incredibly valuable for diagnosis. They appear primarily on the buccal mucosa, that's the inner lining of your cheek, typically directly opposite the molar teeth. Sometimes you might also find them near the opening of the parotid duct where saliva comes out.
Right opposite the back teeth. Wow.
But here's the catch. They are transient. They only last for a brief 24 to 48 hours.
Only a day or two.
Yeah, which means they can be easily missed if you're not actively looking for them during this very specific narrow window. Their fleeting nature, combined with their precise appearance and location, make them an absolutely crucial diagnostic clue for early measles infection. For a dental professional doing a routine oral exam, spotting these could be the earliest clinical sign, maybe even before the skin rash emerges.
Making the dental clinic a kind of unexpected or early warning station?
Exactly. A surprising yet potentially vital front line for early detection and public health intervention.
Okay, so Koplik spots flash up and disappear. Then what? The rash.
Yep. Following the appearance of Koplik spots, usually within about 12 to 24 hours, the characteristic rash of measles emerges. This is described as an erythematous maculopapular rash.
Okay, break that down. Erythematous.
Means red. Maculopapular means it's composed of both flat spots, macules, and small raised bumps, papules.
Red spots and bumps. Got it. Where does it start?
It typically starts on the face, often behind the ears and on the forehead. Then it rapidly spreads downwards, extensively covering the trunk, then the extremities, and finally it can even appear on the palms of the hands and soles of the feet.
Arms and soles too, that's pretty widespread.
It is. And the underlying mechanism for this rash is fascinating in itself. It's primarily caused by your body's own immune system, specifically cytotoxic T cells, a type of specialized immune warrior cell.
So the rash isn't the virus itself, it's our reaction to it.
Largely, yes. These T cells attack the measles virus-infected epithelial cells in your skin. So while the rash is a very visible symptom, it's also a clear sign that your immune system is vigorously fighting the infection. Sometimes that fight causes inflammation and discomfort, hence the rash.
Okay, so our immune system is fighting back hard. How effective is it overall against measles?
When it comes to host immunity, cell-mediated immunity, or CMI, plays an absolutely critical role in controlling the measles infection. Think of CMI as your body's specialized hit squad of immune cells, like those cytotoxic T cells, directly hunting down and destroying virus-infected cells. It's the body's primary way of clearing the virus.
But you just said CMI causes the rash.
See, there's the interesting trade-off. Many of the typical clinical signs we just described, the rash, the widespread inflammation, are actually contributed to by those very CMI-induced inflammatory and hypersensitivity reactions. It's your immune system's vigorous response that causes some of the symptoms and discomfort.
So the cure is part of the symptoms?
In a way, yes. And measles does something else significant and rather insidious to your immune system. It causes temporary immunosuppression.
Weakens the immune system while it's fighting.
Exactly. We see a decrease in certain types of white blood cells like eosinophils and lymphocytes, which are crucial fighters. And there's a depressed response to certain lab tests that measure immune cell activity. This temporary weakening can leave individuals vulnerable to secondary infections.
Like bacterial infections.
Precisely. Bacterial pneumonia or ear infections are common secondary problems, and sometimes these can be more dangerous than the measles itself.
What about antibodies? Don't they help?
Well, antibodies, the other main arm of the immune system, generally play a minimal protective role during the active infection. That's partly due to that clever cell-to-cell spread mechanism the virus uses, which can hide it from antibodies circulating outside the cells.
Ah, right. The sneaky fusion protein.
Exactly. However, maternal antibodies, passed from mother to baby, do offer crucial temporary protection to infants during their first 6 months of life. It's a brief, inherited window of immunity.
Okay, so CMI is key, but causes symptoms and the virus weakens immunity temporarily.
Yeah.
But there's good news, right? About long-term immunity.
Yes, absolutely. Here's the powerful and reassuring fact about measles immunity. One attack of the disease typically confers lifelong immunity. Once you've had it, your body remembers it, develops long-lasting memory cells, and you're protected for the rest of your life.
Okay, so we've got a remarkably detailed picture of measles now. Its intricate viral structure, its stealthy journey, those very specific fleeting complex spots in the mouth, and the fact that one infection usually means you're protected forever.
Pretty much sums it up.
So let's shift our gaze now to its viral cousin, mumps. What does this paramyxovirus bring to the table? How does its structure compare? What's its unique signature attack on the body? And how does our immune system respond? Does it operate with the same kind of stealth, or does it have a more obvious calling card?
Right, mumps. Like measles, it is indeed a typical paramyxovirus. Structurally, it has that single-stranded negative sense RNA genome, the same photographic negative blueprint, all encased within a protective envelope.
Okay. Similar start.
Very similar. And again, that envelope isn't just a simple layer. It features two major surface glycoproteins that are vital for interacting with our cells. First, there's the HN protein.
HN, not just H like in measles.
Correct. HN stands for both hemagglutinin and neuraminidase. This protein has a dual function. Like the H in measles, it enables the virus to agglutinate or clump red blood cells from various species, fowl, guinea pigs, humans.
Okay, the clumping part.
But crucially, it also possesses neuraminidase activity. Remember how measles lacked that?
Yeah, you mentioned that. So what does neuraminidase do?
Think of it like tiny enzyme scissors that can break down certain receptors on the cell surface. This means that after agglutination, it can cleave these receptors, leading to elution where the red blood cells then separate again, usually at body temperature. That's a key difference for measles.
HN does clumping and cutting. Got it. What's the other protein?
The second crucial surface protein is the F protein, or fusion protein. Just like in measles, this is responsible for cell fusion, allowing the virus to get into cells and spread efficiently between them, often bypassing antibodies.
Same F protein function.
Pretty much the same role, yes. And beneath this envelope, you'll also find that matrix, or M protein, providing structural integrity, like internal scaffolding.
Okay, so structurally similar, but with that HN difference. Now let's talk about its signature attack. How does mumps operate in the body?
Okay, pathogenesis and clinical features of mumps. Interestingly, humans are quite unique here, as we are the only known natural hosts for the mumps virus.
Only humans. No animals carry it.
Not naturally, no, which simplifies its epidemiology somewhat. No animal reservoirs to worry about. Transmission is primarily person to person, either through direct contact with an infected individual or, much like measles, through inhaling respiratory droplets from coughing, sneezing, talking.
Okay, droplets again.
Droplets again. And also, contaminated saliva and urine can be sources of transmission, which makes it particularly relevant to environments where you might encounter those fluids, like a dental office, perhaps.
Definitely relevant there. So it gets in the same way as measles, respiratory route.
Yes, the infectious journey usually begins with the virus entering your respiratory tract. It initially replicates locally there, setting up that first foothold, often without causing immediate symptoms.
Stealthy start again.
Yep. Following this local replication, viremia occurs. Virus enters the bloodstream. This viremia then serves as the transport system for the virus to spread and target specific tissues. And for mumps, the primary targets are the salivary glands.
Ah, the classic mumps symptom.
Exactly, especially the parotid glands, the largest salivary glands, located just in front of and below your ears. The central nervous system, the CNS, is also a significant target, which we'll get back to when we discuss complications.
So parotids and CNS are main targets. How does it get to the parotids? Through the blood.
It can, yes. But what's fascinating is that the virus can reach the parotid glands via two distinct routes. Either directly, traveling up Stenson's duct, that's the main tube, draining the parotid gland into your mouth.
Up the duct. Against the flow of saliva.
Apparently so.
Yeah.
Or, more commonly, it arrives through the bloodstream after that systemic spread, the viremia. This dual entry mechanism might explain why the parotids are such a preferred site.
Okay, so it gets into the salivary glands. What happens then?
Well, when the virus successfully replicates inside the salivary duct epithelial cells, it causes quite a bit of damage and inflammation. This leads to something called acinar disintegration. The functional units of the gland start breaking down. You also get periductal edema, which is swelling around the ducts.
Swelling, okay.
And you'll see a mononuclear infiltrate immune cells like lymphocytes and macrophages rush to the site, causing inflammation. And a direct, highly significant consequence of this replication, especially for dental professionals, is that the virus is then shed in high concentrations in the saliva.
Shed in saliva. That sounds risky for dentists.
Extremely relevant, yes. It makes the infected person highly contagious through their oral secretions. Clinically, the hallmark sign of mumps is that acute onset of painful swelling in one or, more commonly, both parotid glands.
That chipmunk's cheeks.
The chipmunk cheeks, exactly. This swelling can make it difficult and painful to chew, swallow, or even open your mouth wide, and it's often accompanied by a constellation of general symptoms. Fever, a throbbing headache, and maybe an earache, which can be quite severe because the swollen gland is right next to the ear.
Ouch. Okay, so it hits the salivary glands hard. Does it stop there?
Not always. Following this primary replication in target tissues like the salivary glands, a secondary viremia can occur. This allows the virus to spread even further through the body to other organs.
Like where?
These can include the kidneys, the testes males, the ovaries in females, and the pancreas. This systemic spread is what accounts for the potential for complications beyond just the swollen glands, complications which can sometimes be more serious than the initial parotitis itself.
Testes, ovaries, pancreas. Okay, that sounds like potential for trouble. What about immunity to mumps? Is it lifelong like measles?
Yes, generally it is. Your body mounts a strong humoral immune response. That's the antibody response against mumps. Antibodies against something called the soluble, or S antigen, typically appear quite early, within 3 to 7 days after symptoms start, indicating an active infection.
S antigen antibodies show up early.
Right. But, more importantly, hemagglutinating antibodies, which target that HN protein we discussed earlier, they are the ones that confer lifelong immunity. So once you've produced these specific antibodies, your body remembers the virus and you're generally protected from getting it again.
Okay, lifelong immunity again. What about CMI, the cell-mediated immunity? Does that play a role like in measles?
It does. Cell-mediated immunity, those specialized immune cells that directly target infected cells, is also essential for controlling the mumps infection and actively clearing out virus-infected cells. However, just like in measles, CMI can also contribute to the pathogenesis of the symptoms. Some of that inflammation and discomfort is, again, a result of your immune system's robust effort to fight the virus.
The double-edged sword of the immune response.
Exactly. But the good news remains. Similar to measles, immunity to mumps is typically lifelong after one infection, providing pretty solid, enduring protection.
Okay, so let's recap slightly. Both are paramyxoviruses. Both can spread systemically. Both usually give lifelong immunity after one infection. Both start in the respiratory tract.
Core similarities, yes.
But their pathways and signature symptoms are quite distinct. Measles gives us those unique Koplik spots and that widespread rash. Mumps' defining characteristic is that painful parotid swelling.
Key differences in presentation.
But what's truly fascinating here, and often I think overlooked, is how they can really throw a wrench into the body's systems, leading to complications that are far from the, benign childhood illnesses they're often perceived to be. This is where the story takes a much more serious turn, isn't it?
Absolutely, and this is so important. While they're often casually dismissed, it's crucial for anyone in healthcare, and frankly for everyone, to understand that both measles and mumps have the potential for severe complications. This really underscores the point that they are not always benign. They can lead to significant, life-altering, or even rarely life-threatening outcomes.
Okay, let's get into the darker side then. Starting with measles complications. What are we looking at?
For measles, respiratory complications are really significant and, tragically, a major cause of death, especially in young children and individuals who are immunocompromised.
Death from measles complications still happens.
Yes, particularly from things like bronchial pneumonia. This often arises from a secondary bacterial infection, which gets a foothold because of that measles-induced immunosuppression we talked about. Measles weakens the defenses, letting other bugs in.
Right, the temporary immune weakness.
Exactly. Other common respiratory issues include otitis media, painful ear infections, and laryngotracheobronchitis, which you probably know as croup. That causes that distinctive harsh barking cough. Less commonly, measles can also lead to severe diarrhea, which is dangerous, especially in young kids due to dehydration risk.
Okay, respiratory problems are major. What else? Neurological?
Neurological complications are perhaps the most concerning and, frankly, pretty chilling. Encephalitis, which is inflammation of the brain itself, occurs in approximately 1 in 1,000 patients.
1 in 1,000. That's not insignificant.
Not at all. And while some people recover fully, it carries the potential for debilitating sequelae, long-term neurological damage like cognitive impairment, motor problems, seizures, or even death. They can be profoundly life-altering.
That's awful. Is that the worst neurological one?
Well, then there's something even more insidious. Here's where it gets really interesting and profoundly chilling. Subacute sclerosing panencephalitis, or SSPE.
SSPE. Okay, what is that?
It's a rare, progressive, and utterly devastating degenerative neurological disease. What makes it so terrifying is that it's caused by a defective measles virus persisting silently in the brain for years after the initial infection.
Wait, the virus stays in the brain for years?
A defective form of it, yes, persists silently. And crucially, its onset is delayed, often appearing a shocking 5 to 15 years after the initial measles infection.
5 to 15 years later, how is that possible?
It's mind-boggling, isn't it?
Someone
Someone seemingly recovers completely from measles as a child, lives a decade or more of a healthy life, only for this defective piece of that old virus to silently start dismantling their brain. SSPE progressively leads to severe mental deterioration, loss of motor skills, seizures, and eventually, inevitably, it results in death.
That's horrifying. A delayed death sentence from a childhood illness.
It's a truly surprising, long-term, and tragic consequence. A viral time bomb. It really makes you reconsider what recovered truly means after measles.
Wow. Okay. Are there oral complications too relevant to dentistry?
Yes, directly relevant. Measles can lead to severe oral and orofacial complications. The most devastating is something called gangrenous stomatitis, also known as NOMA.
NOMA. Gangrenous stomatitis. Sounds bad.
It is horrific. Thankfully, it's not a complication seen universally. It's rare in developed nations. It's particularly prevalent in specific contexts like sub-Saharan African countries, and almost exclusively in severely malnourished children.
Malnutrition plays a role.
A huge role. These children often have concurrent oral ulceration and something called acute necrotizing ulcerative gingivitis, or ANUG, a severe gum infection, sometimes called trench mouth.
Okay, so malnutrition, bad gums, then measles hits.
And the horrifying outcome of NOMA is gross destruction and disfigurement of orofacial tissues. It starts as maybe a small ulcer but rapidly spreads, causing necrosis, tissue, death, and loss of bone, leading to severe and permanent facial damage.
Oh my God. That's beyond awful.
It's a stark reminder that a viral infection like measles, in vulnerable people with compromised immunity and nutrition, can open the door to bacterial superinfections that cause extreme local tissue destruction. For dental professionals, understanding this potential, even if it's rare in their specific practice, highlights that profound link between systemic health, nutrition, and oral hygiene.
Incredibly sobering. The idea of SSPE years later, or the disfigurement of NOMA, measles, is definitely not always benign. So let's turn to mumps complications. You said death is rare, but what about significant or long-lasting issues, especially those reproductive hints you mentioned?
You're right. While death from mumps is thankfully rare, its complications can certainly be significant and, in some cases, long-lasting, given the virus's targets.
Like the CNS.
Exactly. For mumps, neurological complications are also a primary concern, similar to measles in that respect. Meningoencephalitis, inflammation of the membranes around the brain and spinal cord, is actually the most frequent complication, especially in childhood. It presents with symptoms like headache, stiff neck, fever.
Meningoencephalitis.
Encephalitis, actual brain inflammation, can also occur, though less commonly than meningoencephalitis, and it carries similar risks of neurological problems long term.
Okay, neurocomplications for mumps too. What about the reproductive system? That's the one people often talk about with the monks, right?
It is, and it's a significant concern, particularly for males. A specific complication is called epididymoorchitis.
Epididymoorchitis.
It occurs in about 1/3 of postpubertal males who get mumps. So after puberty, it's an inflammation of the epididymis, the tube behind the testicle, and the testes themselves. It can be extremely painful, causing severe swelling and tenderness.
1/3. That's quite common. Does it cause infertility?
It doesn't always lead to infertility, but the rare but severe outcome is testicular atrophy shrinkage of the testes, and that can indeed lead to sterility in one or, less commonly, both testicles. This is a profound and very real concern for young men who contract mumps after puberty.
Sterility. Wow. What about females? You mentioned ovaries.
Yes, oophorytis, which is inflammation of the ovaries, can also occur in females, but it's much rarer for this to lead to fertility issues compared to the potential impact in males.
Okay, so major reproductive risk for males post-puberty. Any other complications from mumps?
Well, given its tendency to replicate in glandular tissue, mumps can also affect other glands. Pancreatitis, inflammation of the pancreas, is a known complication that can cause severe abdominal pain, nausea, vomiting, and affect digestion and blood sugar control.
Pancreas too. Okay.
Thyroiditis, inflammation of the thyroid gland, and mastitis, inflammation of breast tissue, are also recognized, though less common. Generally, you might also see things like arteritis, inflammation of arteries, thrombocytopenia, low platelets, or pneumonia, but again, it's important to stress that overall, death from mumps is rare. The main concern lies in the potential for significant long-term morbidity, especially that reproductive impact in males and the neurological complications.
Okay, so what does this all mean for us? Measles clearly has profound neurological risks like SSPE and those devastating oral complications like NOMA. Mumps, while rarely fatal, carry significant risks for reproductive health, especially in males, and neurological issues too. This raises an absolutely critical question. How do we even know for sure if someone has these? Especially when the stakes with complications like SSPE or potential sterility are so incredibly high, it seems like getting a clear, accurate diagnosis quickly would be absolutely paramount, wouldn't it?
You've hit on a crucial point there, the need for definitive diagnosis. While yes, typical cases of both measles and mumps can often be diagnosed clinically, just based on the classic symptoms and a physical exam.
Like the parotid swelling or Koplik spots?
Exactly. But laboratory tests become absolutely essential for atypical cases or modified presentations. Maybe someone was partially vaccinated or their symptoms are just unusual. And given the potential for severe complications we've just detailed, plus the need for public health tracking and managing outbreaks, lab confirmation is really key. It's like putting together the pieces of a puzzle using a detective's toolkit.
A viral detective's toolkit. Okay, so what's in the toolkit for measles? How do we confirm it in the lab?
For measles, accurate lab diagnosis involves several approaches, and we use a range of different specimens to try and catch the virus or the body's response to it. We can collect respiratory secretions from the nose and throat, conjunctival specimens from the eye, urine, blood.
And in those specific, very serious cases of suspected SSPE, sometimes even brain tissues via biopsy.
Okay, lots of sample types. What do you do with them? Look under a microscope.
Sometimes, yes. Microscopy can be useful. One classic diagnostic sign for measles is finding multinucleated giant cells, often specifically called Warthin-Finkeldy cells.
Giant cells again? Yes, these large abnormal cells with multiple nuclei. You can find them in Giemsa-stained smears taken from biopsies of Koplik spots, highlighting their diagnostic value again, or from nasal secretions, or even from skin samples from the rash. Plus, we can use techniques like immunofluorescence.
Making things glow.
Pretty much. We use specially tagged antibodies that stick to measles antigens within these cells, making them light up under a special microscope. Confirms the virus is there.
Cool. Can you actually grow the virus?
Virus isolation? Yes, trying to grow the virus itself in the lab is another method, though it can be quite challenging for measles. It's a bit fussy.
Fussy virus.
Yeah. But it can be cultured from samples from the nose, throat, conjunctiva, or blood, especially during that highly infectious prodromal phase and for up to 2 days after the rash appears, and also from urine.
And if you manage to grow it?
When it's successfully grown in various cell cultures, like specific types of human or monkey kidney cells we keep alive in dishes, the virus produces characteristic cytopathic effects, or CPEs, visible changes in the cells caused by the infection, like the formation of those multinucleated giant cells we mentioned, and also distinct cytoplasmic and nuclear inclusion bodies, basically. Visible clumps of viral stuff or cell damage.
So you can see the damage it does to cells in a dish. What about blood tests, antibodies?
Horology, yes.
Yeah.
Testing the blood for antibodies is often the most common and confirmatory method for measles diagnosis, partly because it's less technically demanding than trying to isolate the virus.
What are you looking for?
We look for the presence of measles-specific IgM antibodies in a single blood sample, usually taken 1 to 2 weeks after the rash starts. Detecting these IgM antibodies, often using a sensitive test called IgM ELISA, confirms a recent and active infection.
IgM means recent infection.
Generally, yes. Another powerful way to confirm infection, or to check immunity perhaps from vaccination, is to look for a fourfold rise in IgG antibody levels between an acute sample, taken early, and a convalescent sample, taken several weeks later. This shows the body mounted a strong immune response specifically to measles.
So a big jump in IgG also confirms it.
Right. And for diagnosing that chilling complication, SSPE, finding extremely high measles antibody titers, both in the blood serum and in the cerebrospinal fluid, the CSF, those are key diagnostic indicators, shows the virus is persistently active in the central nervous system.
High antibodies in CSF for SSPE.
Okay.
Any other methods, like genetic testing?
Absolutely. Molecular methods are becoming increasingly common, mainly because they're fast and very sensitive. PCR-based rapid diagnostic methods, polymerase chain reaction, are now frequently used to detect the viral RNA directly from patient specimens.
Finding the virus's genetic fingerprint.
Exactly. It allows for quicker and more definitive diagnosis, which is absolutely crucial for rapid public health action and containment during outbreaks.
Okay, so quite a few robust ways to nail down a measles diagnosis. Looking for giant cells, growing the virus, checking for IgM or rising IgG antibodies, or finding its RNA with PCR. Seems pretty comprehensive. What about mumps? Does its diagnosis follow a similar playbook, or are there key differences in how we pinpoint that one?
Mumps diagnosis does share some similarities, definitely, but it also has its own distinct features and preferred specimen types, largely because its primary targets are a bit different. While mumps, like measles, is often diagnosed clinically based on symptoms.
The swollen glands.
Right. Lab confirmation is still very useful, especially for those atypical cases where maybe the parotid swelling isn't obvious, or maybe you need to differentiate it from other things that can cause salivary gland swelling, like bacterial infections or even other viruses.
Okay, so what samples do you use for mumps?
For specimen collection, we have several good options depending on the stage of the infection. Saliva is very common and effective. The virus can be present and shed there for about 4 to 5 days after symptoms start.
Saliva makes sense, given the peritidis.
Exactly. Urine can actually contain the virus for longer, up to 15 days, so that can be useful for later diagnosis. Secretions collected directly from Stenson's duct, draining the parotid, can also be used if the swelling is prominent. And importantly, for cases with suspected CNS involvement, cerebrospinal fluid, CSF from a spinal tap, is critical. The virus might be present there for about 8 to 9 days after neurological symptoms appear.
Okay, saliva, urine, duct secretions, CSF. Can you grow the mumps virus too? Is it less fussy than measles?
Virus isolation for mumps is possible, and often a bit more straightforward than for measles, yes. The virus can be grown in various tissue cultures, like primary monkey kidney PMK cells, HEP2 cells, H292 cells.
And does it cause visible changes, CPEs?
It does. When the virus grows, it produces characteristic CPEs, visible changes under the microscope. These include, again, multinucleated giant cells similar to measles, but also things called acidophilic cytoplasmic inclusions, reddish clumps within the cell cytoplasm.
Okay. How do you confirm it's mumps growing?
We can detect the viral growth using direct immunofluorescence, using labeled antibodies to spot viral antigens, or by something called hemadsorption, where red blood cells actually stick to the infected cells because of that viral HN protein.
Ah, the hemagglutinin part of HN.
Exactly. There's also an older method using egg inoculation, growing it in chick embryos, and then detecting it with assays. Plus, immunofluorescence using specific mumps anti-serum can rapidly detect viral antigen in cell cultures within just 2 or 3 days. Pretty quick.
Faster than full isolation. What about blood tests for mumps? Serology?
Serology remains a cornerstone for mumps diagnosis too, especially for confirming a recent infection. Detecting mumps-specific IgM antibody by IgM ELISA is really the go-to method for indicating a recent and active infection.
IgM again for recent mumps.
Yes. And just like with measles, seeing a 4-fold increase in serum IgM antibody levels between an acute sample and a convalescent sample provides strong confirmation of the diagnosis, showing that active immune response. Other tests, like hemagglutinin inhibition assays or immunofluorescence, can also detect antibodies. But IgM ELISA is typically preferred for diagnosing acute cases because it's sensitive and specific.
Okay, IgM ELISA is key. Any role for just looking under a microscope directly at samples?
Microscopy can play a role, maybe more in research or unusual situations. You can sometimes use electron microscopy on pure parotid saliva and actually see the typical paramyxovirus particles, visualize the virus itself. Also, mumps virus, like measles, might produce both intranuclear and intercytoplasmic inclusion bodies within infected cells, which are signs of viral activity you could potentially see with a light microscope.
It truly sounds like we have a really robust set of diagnostic tools for both measles and mumps, covering everything from, directly seeing the virus or its effects on cells to detecting the body's antibody response or finding its genetic fingerprint. What's fascinating is just the sheer range of methods available. But with all this diagnostic power, what about treatment? Do we actually have specific antiviral drugs that work well against these infections once someone has them?
Yeah, that's the really important follow-up question, isn't it? And unfortunately, the answer is pretty straightforward and maybe a bit sobering for both viruses. Currently, no specific antiviral agents are routinely available or considered widely effective for either measles or mumps.
Really? No specific antivirals?
Not in routine use, no. For most uncomplicated cases of both diseases, symptomatic treatment is usually all that's needed and all that's offered.
Symptomatic treatment means
Just managing the symptoms. The focus is entirely on keeping the patient comfortable, managing the fever, the pain, any other issues, and supporting their body's own immune system while it fights off the virus. So things like pain relievers, fever reducers, making sure they get enough fluids, adequate rest, basic supportive care.
So you just have to write it out, basically.
For most people, yes. Now, for measles, there has been some evaluation of an antiviral drug called ribavirin, particularly for severe cases or in people who are immunocompromised. But this is still mostly based on lab studies, in vitro work, and it's definitely not a standard, routinely available treatment option for the general public.
Okay, so ribavirin is maybe looked at for severe measles, but not standard.
Correct. So for both measles and mumps, the focus remains very firmly on supportive care for those infected, and crucially, on prevention in the first place. Because once the infection is established, we're largely relying on the body's own natural defenses to clear it.
Right. Prevention is key then. Okay, let's really unpack this crucial aspect now. What do measles and mumps actually mean for you? Whether you're a dental practitioner, working in a clinic every day, or maybe you're just someone visiting the dentist for a routine checkup. Our sources really highlight some significant implications that connect these seemingly distant childhood illnesses directly to oral health and, critically, to clinic safety. This is where all that virology and pathogenesis translates into real-world action, right?
Absolutely. This is truly where the deep dive connects with practical healthcare, especially in dentistry. The oral manifestations of these diseases aren't just, interesting footnotes in a textbook. They are diagnostically and clinically important. They can offer early clues that might change a patient's entire course, and they also pose direct transmission risks within the dental environment itself.
Okay, let's break down those oral signs again, focusing on their importance. Measles first.
For measles, as we discussed, complex spots are those truly pathognomonic early signs. And I want to reiterate their profound importance. These distinctive bluish-white pinpoint lesions, each surrounded by that dark red halo.
Opposite the molars.
Primarily on the buccal mucosa.
Yeah.
Yes, often opposite the molars, sometimes near the parotid duct opening. For a dental practitioner, recognizing these spots is absolutely critical because they appear during the prodromal phase, the period of maximum infectivity, and they often show up before the skin rash.
The early warning system again?
Exactly.
Yeah.
Think about it. A child comes into your dental practice. Maybe they just have a fever, a runny nose, no rash yet. But then you, the dental professional, doing a routine oral exam, you spot these tiny, almost weirdly specific bluish-white dots inside their cheek. In that instant, you haven't just seen a symptom, you've potentially seen the earliest, clearest diagnostic sign of measles, maybe days before anyone else would.
That's a huge aha moment potential right there.
It really is. It translates directly into the possibility for earlier diagnosis, quicker isolation, preventing further spread in the community, and crucially preventing spread within your own clinic. It makes the dental setting, quite surprisingly, a vital front line for early detection in public health.
Okay, complex spots, huge diagnostic clue for dentists. What about the other measles oral issue, the really severe one?
Right. On the much more severe and, frankly, alarming end of the spectrum for measles, we have gangrenous stomatitis, or NOMA. Again, while it's less common in developed nations, its existence highlights the profound and devastating link between systemic health and oral health. As we mentioned, it's a severe complication often seen in severely malnourished children in specific regions, frequently alongside existing oral ulcers and that severe gum infection, AONUG, or trench mouth.
And it leads to destruction?
Horrifying and extensive tissue destruction and disfigurement in the orofacial region. It might start small, but can rapidly progress, destroying soft tissues, bone, cartilage around the mouth and face. This isn't just a sore, it's a rapidly progressing, devastating infection. It really underscores how interconnected overall health, nutrition, and oral hygiene are, and the potential for a common virus like measles to kick off a cascade of severe oral pathology in vulnerable individuals. It's a stark reminder of the bigger health picture.
Truly sobering. Okay, moving to mumps. What's its defining oral sign?
For mumps, the defining oral manifestation is acute parotitis, the painful swelling and inflammation of one or both parotid glands. It's what most people immediately picture when they hear mumps, that characteristic chipmunk cheek look.
Chipmunk cheeks, right?
Clinically, you'll see that visible swelling just in front of and below the ear. It can make chewing, swallowing, even opening the mouth wide, incredibly difficult and painful. Often, if you look inside the mouth, the opening of Stenson's duct, where the parotid drains, will appear reddened and inflamed, signaling that active infection within the gland.
Reddened duct opening, okay.
And what's absolutely crucial for the dental environment is the underlying mechanism. The mumps virus specifically infects those salivary duct epithelial cells. And as a direct result, the virus is shed in high concentrations in the patient's saliva.
High concentrations in saliva.
Exactly. This shedding means the oral cavity itself becomes a direct, active source of infectious mumps virus, transforming it into a high-risk area for transmission during dental procedures or even just close contact.
So, if the virus is literally being shed in saliva for mumps, and measles has Koplik spots appearing in the mouth during its most infectious stage, what does that concretely mean for transmission risk in a dental setting where, close contact and aerosol generating procedures are just part of the daily routine? It sounds like a potentially high-risk environment, not just for other patients, but for the entire dental team.
You're absolutely right to identify that as a paramount concern. Both measles and mumps viruses are highly contagious, and their primary modes of spread respiratory droplets and direct contact with infected secretions, including saliva, are incredibly relevant to the unique environment of a dental clinic.
Droplets and saliva, the two things dentists deal with constantly.
Precisely. For mumps specifically, the infectious period is particularly broad and challenging for containment. Individuals can be infectious from about 9 days before the parotid swelling even starts.
9 days before, they wouldn't even know they have it.
Exactly. They might feel a bit off, but not realize it's mumps, and certainly might not think to cancel a routine dental appointment. And they remain infectious for up to 7 days after the swelling begins. This prolonged presence of mumps virus in saliva throughout this extended period poses a direct and significant transmission risk within the clinic.
How does it spread there?
Through direct contact with contaminated surfaces, chair handles, light switches, instruments if not properly sterilized, or even just close conversation, but especially through droplet spread. Any procedure that generates aerosols, which is common in dentistry.
Drills, scalers, air water syringes.
All of them. They amplify the risk significantly by dispersing that virus-laden saliva into the air.
Okay, mumps is risky due to saliva shedding over a long period. What about measles transmission in the clinic?
Measles, too, has extremely high transmissibility. It's famously one of the most contagious diseases known. Its peak transmissibility, remember, is during that prodromal phase, before the full rash appears. And of course, when the rash does appear, the patient remains highly contagious for several days afterwards.
So again, infectious before the obvious signs.
Right, which means an infected patient could be sitting in your dental chair, shedding the virus through respiratory droplets, potentially transmitting it, even before they develop the classic symptoms that would make them cancel or seek specific medical care. This silent spread during the pre-symptomatic or early symptomatic phase makes both viruses particularly challenging to contain in a setting like a dental clinic, where close face-to-face interaction and aerosol-generating procedures are unavoidable parts of the job.
This definitely raises that important question again. Knowing these inherent risks, the high contagiousness, the oral manifestations, the shedding in saliva, what practical, actionable steps can dental professionals, and frankly, anyone interacting within that clinical environment take to manage and prevent the spread? Not just of measles and mumps, but infectious diseases generally. It sounds like vigilance and really robust protocols must be absolutely paramount.
Vigilance is indeed paramount. Absolutely. And thankfully, we have robust, evidence-based protocols already well established in dentistry to mitigate these exact risks. The management and prevention of these viral transmissions hinge on a multifaceted approach, really emphasizing layers of protection.
Okay, what are the key layers?
First and foremost is patient evaluation. Dental practitioners should always take a thorough medical history from every single patient. And it's absolutely critical to update this history at each recall visit, not just the first time they come in.
Why update it every time?
Because things change. It's not just a formality. It's a vital screening tool to identify any infectious diseases of concern that might have cropped up since their last visit. This includes asking specific questions about recent fevers, unexplained rashes, any swelling around the face or neck signs that could potentially indicate early measles or mumps. Asking about recent travel or known exposure to illness can also be crucial.
So good history taking is the first line of defense.
It is. Beyond individual patient assessment, implementing rigorous infection control measures is absolutely non-negotiable. The good news here is that standard universal infection control measures, when they're followed diligently, are generally highly effective in preventing disease transmission in the dental setting for most pathogens, including these viruses.
Standard precautions, like what specifically?
Let's break down some key components.
Yeah.
Personal protective equipment, or PPE, is paramount. This includes the routine wearing of gloves, creating that physical barrier against saliva and blood. Face masks, ideally surgical masks, or even N95 respirators, depending on the procedure and risk assessment, are essential to block droplet transmission, both from the patient out and from the environment into the professional's airway.
Masks are key for aerosols.
Absolutely. And eye shields or protective eyewear are also vital to prevent microbes getting into the mucous membranes of the eyes, another potential entry route. This comprehensive use of PPE is particularly critical during those procedures that generate aerosols using high-speed drills, ultrasonic scalers for cleanings, air-water syringes. These procedures can disperse viral particles widely if PPE isn't used correctly.
Okay, PPE, gloves, mask, eye protection. What else?
Environmental disinfection. This means regular, thorough disinfection of all clinical surfaces. Equipment handles, chair controls, countertops, anything that might be touched or contaminated after each and every patient. This breaks the chain of transmission from surfaces.
Cleaning between patients is crucial.
Absolutely. And proper sterilization of all reusable instruments is, of course, fundamental. Additionally, strict adherence to sharp safety protocols is vital to prevent percutaneous transmission getting infected through skin punctures from needles or sharp instruments. Using safety devices, handling sharps carefully, and disposing of them correctly in puncture-resistant containers is key.
Okay, PPE, disinfection, sharp safety. That covers a lot. Is there anything else?
Yes. Arguably, the single most impactful preventive measure, especially when we're talking specifically about measles and mumps, is immunization. Vaccination is the primary preventive tool, both for the general population and, crucially, for dental healthcare personnel as an occupational health requirement.
The MMR vaccine.
Exactly. The combined measles, mumps, rubella, or MMR vaccine, is the cornerstone of prevention. It uses live attenuated strains of these viruses.
Live attenuated means weakened.
Weakened, yes. They've been modified in a lab so they can stimulate your immune system to produce protective antibodies and memory cells, but without causing the full-blown disease. And it's highly effective.
Who should get it? Just kids.
It's recommended for all children as part of routine immunization schedules worldwide, and it's dramatically reduced these diseases. But just as important, it's strongly recommended as an occupational vaccine for any non-immune dental team members.
So dentists, hygienists, assistants should all be vaccinated.
If they don't have evidence of immunity from prior infection or vaccination, yes. This is especially vital for women of childbearing age on the team, not only to protect themselves, but also to reduce the risk of transmitting these infections to vulnerable patients like infants too young to be fully vaccinated, or immunocompromised patients, and also to avoid potential complications during pregnancy, although rubella is the main pregnancy concern within the MMR vaccine itself.
How long does the protection last?
It's generally very good and long-lasting. A single dose of the measles component provides protection for over 20 years, often lifelong. For mumps, the vaccine confers about 95% protection for at least 12 years, maybe longer. Usually 2 doses are given in childhood for optimal long-term protection against all 3 diseases.
That's pretty impressive protection. Are there people who shouldn't get the MMR?
Yes, there are important contraindications because it's a live attenuated vaccine. It is generally contraindicated during pregnancy. That's a key point for any healthcare setting. And also in people who are severely ill or significantly immunocompromised, like those undergoing certain cancer treatments or with specific immune deficiency disorders, their weakened immune systems might not be able to handle even the attenuated viruses safely.
So for those people, strict infection control is even more critical.
Absolutely. For them, rigorous avoidance of exposure and strict adherence to infection control by everyone around them become their main lines of defense.
Okay. So tying this all together, what does this really mean for you, the listener? It seems to mean that understanding these viruses, their structure, how they spread, how they show up in the mouth, and these really straightforward but vital preventive measures, it isn't just, academic knowledge for scientists.
Not at all.
It's fundamental. It's about ensuring patient safety, staff safety in any healthcare setting, but especially in dentistry. It really underscores that your dentist and their team, they aren't just looking at your teeth in isolation. They're part of this broader healthcare ecosystem. They're constantly vigilant for signs that could impact your overall well-being, and they're working incredibly diligently to maintain a safe, infection-free environment for every single person who walks through their doors.
Yeah.
Wow. We have certainly journeyed deep today, haven't we? From understanding the intricate structures and stealthy pathways of measles and mumps viruses, tracing their journey from the respiratory tract right through their systemic spread.
Mm-hmm.
We then confronted their potentially severe complications, from that truly chilling delayed neurological impact of SSPE, that viral time bomb, to the horrific oral destruction of NOMA, and those significant reproductive concerns tied to mumps, especially for males.
Yeah, some really serious potential outcomes.
And finally, we brought it all right back home, dissecting their specific and profound implications for oral health and dental practice. From those early diagnostic signs uniquely visible in the mouth, like Koplik spots, to the absolutely crucial infection control strategies that keep us all safe.
And if we try to sort of connect this to the bigger picture, the key takeaways seem really clear and incredibly practical. Recognizing those pathognomonic oral signs, Koplik spots for measles, acute parotitis for mumps, can be an early, vital warning. It really could transform a routine dental visit into a critical diagnostic moment.
That potential is huge.
It really is. And the high contagiousness of both viruses, particularly through saliva and respiratory droplets, just underscores the unrelenting need for constant vigilance and adherence to protocols in clinical settings. And maybe most importantly, the vital role of robust infection control measures, combined with the proven power of immunization through the MMR vaccine. These are our strongest, most reliable defenses, protecting both patients and dental professionals from these often underestimated yet potentially very potent viral adversaries.
So here's a final provocative thought for you to maybe chew on. If a simple routine dental checkup can potentially reveal early critical signs of a systemic viral infection like measles, or even provide insights that could help halt its spread in a community, what other seemingly isolated medical fields might hold surprising, profound insights that impact our overall health and well-being? What crucial connections are we maybe still missing right in front of us between different areas of medicine, or even between medicine and our everyday lives, that could unlock even greater health outcomes in the future? Thank you so much for joining us on this deep dive. Keep exploring, keep learning, and we'll catch you on the next one.